I'll be then moving on to another new technology, which is the ray tracing aberrometry for corneal and lens-based refractive surgery. And I think it's important for us to have the proper concept of a wavefront. So just imagine that there's a parallel beam of light, and once it crosses the media, this beam of light bends. Usually it focuses on the retina, and in this case this beam is not focusing on the retina, because so this is the ideal wavefront, which is the dashed line which would make the beam focus, and we have the dark line which actually tells us the real wavefront, and the difference in microns is what we measure and what we call is the wavefront aberration or wavefront error. This is an example of an irregular wavefront. So the beams of light are going crisscross. So of course the patient is going to have symptoms. Patient is going to have glare, halos, ghosting, and all of the symptoms which can be explained by these kind of aberrations which occur once the light passes through the eye, through the media of the eye. So we have the corneal aberrations, and we have the internal aberrations, by which we mean the lens and the media of the eye. And overall, then we can study the total corneal aberrations. So these have been mapped into significant higher order aberrations, which are usually of 6 orders, which are visually significant. So what is aberrometry? Aberrometry is the science of analyzing ocular aberrations. And we have different types of aberrometers. So there are different technologies are there. They work on different principles. So we have the Hartmann check, which have lenslets, and there are fixed spots with the churning. And we have something like a retinoscopy kind of a principle for the skioscopy. Now, in normal eyes, they work very well or fairly well, but they do have some limitations. They measure all the points at once. So there's a crossover effect when there's some points can cross over, and they are highly sensitive to noise. They're slow, require multiple scans, but more importantly, they cannot measure accurately in highly irregular eyes or in highly aberrated eyes. There's a data confusion, and it's not physiologic with the real vision. So the eye trace is one of the newer modalities. What it does is it sends in infrared laser beams of light which focus on different parts of the retina, and these are 64 laser beams, and they are shot in 4 times into the eye. So total of 256 spots are studied, and this is used to generate a very unique point spread function. And what happens is that this is then used to generate data for the eyes. So these are the two kind of maps. So we also have the Placido based topography of the eye. So we have the autorefractor, which is very accurate. We have a Placido topography, we have the ray tracing, we have the pupillometry, and we have the autokeratometry. So it has a lot of qualities. So when we start analyzing the eye trace maps, one is the data verification, and this is very important, that because if we get trash into the machine, it's going to be trash out. So this means we need to verify that the data we have captured is not getting confounded by some artifacts. Wavefront display is there, so just at a glance, so if we see a smooth green map, it just shows us that the wavefront is very regular in this eye. On the other hand, if we see multitude of colors, especially bright colors, dark colors, it indicates that this eye probably has significant wavefront aberrations. The Chang analysis gives us ocular aberrations in a very simple format, and it gives us quantifies it, and we can just see, and it color codes it. So it's a very easy to spot that, okay, there's something wrong with this eye. For example, we see there are red marks here. The red aberration means they are significant. If they are white, they are not significant. So how does the eye trace help us in planning cataract surgery? Some of these points are valid even for refractive surgery, and I will not be repeating them for that. One, the most important question which comes to our mind is, do I need to operate this patient for cataract or not? For example, this is a 32-year-old female, came for LASIK surgery, has a blue dot cataract. So many times there are different grades of blue dot cataract, and we wonder, how can we actually decide whether this patient needs cataract surgery or not? So the ITIS gives us a grading of the cataract, which is based on entirely the laser beams which are going into the eye and how they are analyzed. So any grade which is more than 2.5 is safe to operate on. It means that the quality of vision after cataract surgery will be significantly better in this patient. So we can see these are different grades of of cataract or opacity grade which we see on the eye trace. It also has a vision stimulator. So just see this. It is not only a good tool for us to understand what the patient is talking about, but it's also important tool for us to explain to the patient, "Okay, listen, I understand what's going on, or this is what is going on with your eye," and this is something which patients really appreciate when we show them. So there's something known as a dysfunctional lens index. Now this is a term which is coined. It quantifies a dysfunctional lens, which is due to natural aging changes, or there's a diminished optical performance for various reasons, which can be a possible source of patient's discomfort in the absence of a cataract. And this is calculated in a based on higher order aberrations, visual acuity, contrast functions, MTF. So many things are taken into account when the DLI is given. So any DLI of less than 5 may be considered for surgery as long as it matches with your clinical acumen, what you should do. Now I'm giving an example of this 52-year-old male. This patient actually had undergone a CT scan, was about to undergo some complicated neurological procedures, and he came to us. He says, "I'm having diplopia, and I'm not satisfied with my vision. Advised an eye trace," and this is the entire segment of this patient. So we can see that this patient had a lower DLI, one, and secondly, we can see that he has a kind of diplopia on the simulation chart, and we could actually explain to the patient, "Don't worry, if you get a cataract surgery done, you'll be fine." Another important question is the patient a good candidate for a multifocal intraocular lens? Now, one of the steps to plan it is angle alpha d and angle kappa. Now we know that angle kappa is actually the angle of the visual axis to the pupillary center. So this is more important for patients who want to undergo refractive surgery and other procedures. Whereas angle alpha, what it actually means is it tells us how well the intraocular lens is going to center in the bag once we put the IOL in. So this angle alpha and angle kappa should be less than 0.5 millimeters. This is given in one corner on the screen in the alpha kappa map. So a simple algorithm for IOL selection using the eye trace. One, when a patient comes to us, when we are assessing for cataract, perform the eye trace and we assess the optical alignment with angle alpha and angle kappa. Now, if the angle kappa is more than 0.5, this patient is a candidate for monofocal IOLs. On the other hand, if the angle kappa is less than 0.5, then we look at the Chang analysis. Now, especially we look at the corneal aberrations. So if the corneal aberrations are less than 0.414, or if they're more than 0.14. So if their corneal aberrations are more than 0.14, we should go in for a monofocal lens, preferably a spherical IOL, and that will possibly give the best kind of vision to this patient. If the corneal aberrations are less than 0.14, then we look at the Iol selection screen. So one of the screens is also the Iol selection screen. And then we can go ahead and plan for a toric or a multifocal IOL. So this is just an example of a patient. This is the Iol selection analysis. It actually even gives the potential visual complaints, matches very well with what patients say in my experience. It tells us at a glance, are the corneal internal aberrations we take care of when we do the cataract surgery. And also it tells us whether this patient is a fit candidate for premium IOL, as in this case he is. Also identifying lenticular problems of possible refractive surgery candidates. This patient was referred for refractive surgery, and if we look closely, just a glance at the dysfunctional lens display shows us that there's something wrong with the lens rather than the cornea. And a closer look again at the Chang analysis shows us that there is a considerable aberrations which are unexpected, and this patient on dilatation had a lenticular coloboma. And this is the wavefront map. Again, just a glance at the multicolors of this wavefront map shows us that this is a possibly patient has a lot of aberrations. So many times we've wondered if whether to YAG a PCO, is this patient going to improve significantly? So these kind of PCOs, this is the eye trace map. It shows us that the patient is having some visual disturbance due to the posterior capsular opacification, and it should be YAG. The patient with the tilted IOL, again, we saw considerable coma in this patient. He had a scleral fixation IOL, and we could see that this tilted lens was causing astigmatism. Better understanding of the patient's vision. This has an aperture, and we are able to see the wavefront maps at distance as well as when he is accommodating. This is my map,
Sorry
far, near,
for
and when we accommodate, it's a +1 diopters of accommodation. So it's so simple to measure the actual accommodation. It also gives us functions like the point spread function and the strial ratio. Basically, what would a point of light look like on the retina? Okay, and this is quantified on basis of the strial ratio. So it's so easy for us to actually quantify how the patient is, including now the MTF. What is an MTF? It's a measure of the contrast. So we have the image and we have the image on the retina. So actual object to image contrast is measured by using the modulation transfer function, and it's one of the important units of visual performance. So this is in a just an example of a patient. We can see this patient was -2 cylinder, and we decided to lift up the flap and just zap the patient, and we could see afterwards, after the surgery, the patient has improved considerably. The MTF has improved and the patient was very happy. To conclude, a 2020 unhappy patient is unacceptable in the 21st century, and in this new era of cataract and refractive surgery, it is an invaluable tool, the eye trace, not only in surgical planning, also communicating to the patient, understanding the outcomes of surgery, and so many applications of this instrument, I think, that we yet have to fully understand. Thank you very much.